Okay, got
Well,
it.
hello, everybody, and welcome to this episode. My very special guest today is Dr. Cliff Tao from originally in Canada, in Ottawa, but now is in Irvine, a nice, good old Scottish name, in California. So welcome, Cliff. Good to see you.
Thank you, Wayne. Thank you for having me.
So Dr. Tao is a renowned, has owned and operated a wonderful chiropractic radiology practice for almost 20 years now. And he did graduate in Chicago from the National University of Health Sciences. And then he went on to do something very unique as a chiropractor, which is a residency in chiropractic radiology. So this guy knows a lot about x-rays. And then he went on to do more stuff around his field, and he's become an international sought-after speaker. He runs his own conference once a year in the beautiful Mammoth Mountains in California. And it's a privilege to have him here today to talk about himself, about what he's doing, and the future where he sees that chronic pain could be improved upon with his services and the services of others like him in his area. So welcome, Cliff, and let's introduce by just tell us a little bit about you, maybe personal, so we get to know you, and let's move on to what you're doing in your career.
Sure. Thank you, Wayne, and thanks everyone for tuning in. So I'm, like Wayne said, I'm a chiropractic radiologist is what I call myself. I'm a chiropractor and I do radiology. And welcome to my home. This is my my office right here. And as you can see, on this side, I have that's myself skiing. So that's a picture of myself skiing. There's a little orange sign there with my name, Cliff, on. I did not steal that. I actually purchased that at the store. But if you're familiar with it, they post those signs up right before you go over a cliff when you're skiing. And I used to always, in my younger days, I would get close. I would never go over. I was never had the kahunas to do that. But so I thought, oh, I'll just buy one and make it look like I'm cool. So I like the outdoors. I like skiing and hiking and mountain biking and things like that. And I'm in Southern California, like Wayne said. I'm in a town called Irvine. I didn't know it had a Scottish background, so thank you for that. And I'm here with my wife, who's just on the other side of that door. She's working hard on our call right now, and we have a wonderful 5-year-old son who's in school right now. So that's those are the things that consumes us. And we're just finished Halloween, so we've just come off of, I think we had 3 or 4 or 5 different Halloween costume parties. So we got good mileage out of our costumes this year, which I'm very happy about.
Oh, brilliant. Okay, so take us into what made you go from chiropractic school to chiropractic radiology, and what is that?
Oh, well, my dad is now retired, but he's a medical radiologist. So he went to, well, get this, Wayne, I don't know if you knew this. My dad is much older. He's in his late 70s now, but he went to medical school in Taiwan. I believe he did his residency there too. And at the time they had this program where you could work in the US or Canada, but they had requirements you had to fulfill. And the requirement for working in Canada from Taiwan legally was that you had to redo medical school and redo your specialty training. But that was the only way to do it. So my dad and a bunch of his friends said, okay, 7 more years, let's do it. So he went to medical school again at McGill in Canada, did his residency training again in Canada, and then started working there. So he's a medical radiologist, now retired. And I think we share that same characteristic. We like details, we like little nuances, analyzing things. It may not seem like it right now, but we're not real social people. We're not inherently extroverted. I think I'm slightly more introverted than extroverted, but I do like the social aspect, and I'm learning, especially since I got married, that there are other people in this world with different types of personalities and all things like that. So that, I think, what was the background of me getting into chiropractic. I had applied to other schools at the time, but I wanted something well, first of all, I don't think I got into medical school, or I didn't even apply to medical school. I applied to physical therapy school. I was interested in the human body and sports and how the body works and how to heal it if it's broken. And a lot of my friends were going to chiropractic school. This was after college or after university, and they had similar interests as me. And even picking a chiropractic school, I just followed where my friends were going. I did not do a whole lot of research, is what I'm saying. And so I went to chiropractic school with the intention of graduating and practicing as a conventional chiropractor and treating sports injuries. That's what I like to do. And then during my time at National, where I went to school, this was in Chicago, we were learning about radiology, and something just, clicked, or, not quite an epiphany, but it was a little light bulb went off, and it was like, oh, I could just look at x-rays all the time and, not have to talk to anybody. That sounds very enticing to me. And but then I was like, oh, it requires 3 more years of school. I think I could do that. It sounded a little bit hard, but I think it gave that, what I also enjoyed was just having an extra level of education and a little more, I guess, certainty. I found the patient practice process, there are a lot of grays. It was a lot of possible probables,
Mm.
and we have that in radiology too, but at least you could say with confidence that that there was low probability or high probability, and everything was black and white, with a bunch of grays in between. And that, I think provided a little bit of comfort to me, because it gave me a defined endpoint to patient care almost. Oh, I do the x-ray report, and that's usually the last I'll hear about the patient.
Okay.
And that kind of, interestingly enough, it probably sounds bad coming from a chiropractor, but I like that endpoint where I did not have to deal with any more patient care type of scenarios after that.
Mm. It's fascinating because, okay, so you're a chiropractic trained, you're a radiologist essentially within your field, and you're
Hmm.
not seeing patients. You're
That is
just
correct.
doing X-rays all the time. Okay, so let's dive into the world of X-rays,
All
because I'm
right.
sure people listening today, they know what an X-ray is. Everybody knows what an X-ray is, but you know, it amazes me as a family doc, for over 20 years, that how little an X-ray actually makes a difference in the clinical management of a patient. Now, most people
That's
probably don't know that, but it's
that's
true,
very true.
right?
Very true.
Degenerative disc disease, um, disc bulges, spondylolisthesis, which is just one bone is slightly sticking out over the next, or spondylosis, which is arthritis, or degenerative disc disease, that same sort of thing, arthritis. So, can you just open our minds and give us some insights based on your knowledge, based on how do you actually help people with these things on an X-ray?
Sure, Wayne. So my job is to help chiropractors with their X-rays.
Right,
They send us X-rays from wherever, and they want to know what I see on the X-rays, good or bad.
right.
And you mentioned that X-rays don't do a whole lot in terms of changing clinical management of a patient. For example, for chronic low back pain.
Mm.
Yeah, and that is the conventional thinking
Yes.
within medicine, and even we were talking about this a little bit before offline. Chiropractic is kind of broad, not in terms of scope, but maybe in terms of philosophy. So we have on one side of chiropractic, they're like physical therapists, very conventionally medically oriented,
Mhm.
but holistic. And then on the other end of the spectrum, and these are very divergent parts of of our profession, and they're very holistic, and they're almost anti anything else. And so I can also have two different answers. So for the one, the more medically oriented guys, they don't use X-ray very often, because it does not change how they're going to manage or treat the patient. But on this end, these are the more vitalistic oriented chiropractors. Some of you may have heard of them as more philosophically oriented or subluxation based chiropractors. And, in the most extreme sense, these guys look at your spine. They take x-rays very frequently to assess for alignment changes, not necessarily serious pathology, although they would look for that too. But they base their treatment, meaning how they're going to manipulate or adjust your spine based on, well, a number of different things. But one thing for sure is what your x-rays look like and how the bones are turned one way or leaning one way or another. And so for them, it makes a humongous clinical difference whether they have x-rays or not. And some of them would even, well, I don't know for sure, but they make it sound like they would not even practice if they did not have x-rays. And so I serve both ends of our profession. And it's, for me, it's been very interesting. I almost have to come up with two different reports sometimes. But it is vital to, especially, this side of chiropractors that base a lot of their treatment regime, management protocols on what they find on the x-ray.
This is your host, Wayne Phimister. Thanks for enjoying the show today. Today, I'm advertising my Healing Chronic Pain course. Now, it covers the new science of how your brain can heal pain. It covers the heart-brain connection, as well as the gut-brain connection. Also, I dive into inflammation, how you can heal that, and optimize movement as you move towards a new reality in your body. So check it out on the link below. Enjoy the show. That is truly amazing, because as I was saying before as well, I haven't came across a chiropractor who uses an x-ray.
Oh,
to decide upon what to do, because there's it's so limited services. I guess that's one big reason. The second reason, they're not all trained to do it,
yeah.
and have it as a part of their management plan. That's for sure.
That's right. Yeah. And actually some, chiropractors also have another thing to deal with, from province to province, state to state, and for sure from country to country. We have a very different scope of practices that, in some countries we're not even allowed to order x-rays, let alone read them. And so the practice of chiropractic can be almost dictated by the country, and sometimes if you're in the US, the state, or in Canada, the province that you're in. So actually right now in British Columbia, there's, I don't know what they decided or if it's still ongoing, but they're thinking of limiting the ability of chiropractors to order or perform x-rays in their own office.
Okay, well, with that in mind, what are the benefits that that chiropractors can get from, say, the findings of a osteophyte at C5-6, which is just an overgrowth of the bone at the commonest level, I think, where these changes, the degenerative disc, age-related changes occur. So what does that mean for the chiropractor?
Well, so I have two different answers, and I think they both work depending on which chiropractor we're talking about. So overall, on the more medical side of things, we have these chiropractors. If they see a degenerated disc, like you say, with osteophytes at the level of C5-6, then probably to them, and if the patient has neck pain that correlates to that level, they might say, oh, you have this very common finding. You have a degenerated disc. We see it very often, very commonly in someone of your age. And, you don't have any really serious symptoms like, like a worsening muscle weakness or something like that, or even severe pain. I think without any serious neurologic deficits, like I mentioned, if they have a muscle weakness or something, I think can be treated conservatively. And but at the same time, they might say, this is probably not a big deal. Even the osteophytes, they may look kind of ominous on the x-ray. They may say that those are not really clinically related because there's nothing that the osteophytes can really poke into. Well, unless they're, humongous, and then maybe it could cause some difficulty swallowing or something like that. And then over here on the more vitalistically oriented guys, they will probably say the same thing, but they're very biomechanically oriented. Well, both are, but maybe more so on this side. And so they may say, although we see this finding very often, it's because you have altered biomechanics, and maybe that was a predisposing factor to you developing these osteophytes and developing the degenerated disc, and that may give them a clue as to how they would treat what they would call the underlying cause. Another thing I didn't mention earlier was that the chiropractors on this end tend to use a term subluxation, and I think it's actually a poorly defined term. I know in medicine, a subluxation, is very well defined. It's anything less than a dislocation. And but in chiropractic, we use a term. It's the exact same word spelled out, subluxation, but the definition doesn't, or not everybody's chiropractic definition of subluxation is the same as the medical definition. Some will say you can't detect a subluxation on an X-ray, and some of them will say you have to detect it on a thermography scan. Thermography is just just for your listeners, it's a process where you detect the different types of heat coming from different parts of your body.
Mm.
And they may use that and say, oh, you have a subluxation here, at the C5 level, but if you took an X-ray, it may look absolutely normal. So, but they would use that to help determine where and maybe how to manipulate or adjust your spine.
Okay. So you're looking at X-rays, CT scans, MRIs. You look at all the different imaging within your field, or?
We do most of our stuff is plain X-rays or radiographs, and we do some CT and MRI as well.
Okay, so let's talk about your international speaking, because you mentioned that in your bio. So what are you talking about at these conferences?
Oh, Wayne, I wish I could talk about more, but it's anything and everything to do with radiology. I feel like I don't really know anything else anymore. And so anything they want to know about radiology, typically, I just I'll make up a presentation with different cases, mostly spine, depending on the meeting. There's some meetings where they want to see extremities because they still see them, but they feel like they need a refresher. And so and mostly it'll be plain radiographs and maybe correlated with CT or MRI.
Right. Okay. So it's almost it's, as you mentioned, it's an educational platform. So we all need to be educated and re-educated, especially on things we don't spend much time on. And
I
we
agree.
don't like that, right? As professionals, we need to know what's going on. So I guess recaps all the time and cases is a brilliant way of demonstrating, because we can all relate to cases because that's what we see all the time. Just taking you through them. So so give us an example of, say, an interesting case that you had recently at a conference.
Well, here's one. This is a chiropractor, and I think he's in Spain. And I think we actually met once before when I was speaking in Spain. He was organizing a meeting, or actually, sorry, I'm thinking of the wrong Spanish chiropractor. He was an author, and we collaborated on a book, and I've since gotten to know him, and he sent me his X-rays and MRIs, and he said, and he's relatively young, I think in his early 40s, but he just had some, not even pain, just some stiffness or tightness in his upper back that just was not going away. And at first I thought, it's probably nothing, just like a tight muscle or something. But for someone to get an X-ray, it almost requires that a little bit of more seriousness. But he also had an MRI, and I'm like, oh, okay, so this is probably something serious, although it doesn't sound like it is. And so, looking at his X-rays and MRI, they both showed a very subtle compression fracture. And you might think, or what I thought was, how did he get this fracture? He swears he didn't fall or have any kind of trauma. He's relatively healthy as a chiropractor. He eats well, and or I thought he ate well, and he exercised regularly.
Mm.
And so it turned out, I said, well, you have a fracture here and it looks relatively acute. On MRI, you can kind of tell if it's new or old, or maybe medium, or what I call subacute. And I said, yeah, it looks maybe months old. It's definitely not years old. And I don't know exactly how long you've had it, but it's definitely there. And you could see some swelling in the bone. I'm sure you've seen before. And I said, well, without any trauma, then we worry about the quality and the quantity of how much bone you have. Is your bone abnormal? So abnormal meaning it's weaker. So even, if you trip and miss your step or something, miss one step as you're going down the stairs when you have some unforeseen, compression, and could that cause a fracture? Or sometimes you sneeze too hard, and normally that would not cause a fracture, but if you have bad bones, then that could cause a fracture. And so it ended up being that he did have osteoporosis. And as you know, Wayne, there's many different causes for osteoporosis, and you wouldn't really think of it in a 40-year-old man.
Mm.
And it turned out that it was because he was indoors too much, not eating well, and he was not getting enough sunlight, and not enough vitamin D. And so he had vitamin D related osteoporosis.
Mm.
And before that, he thought he had some parathyroid issue, and he was going to fly to the US to have the surgery. And I said, I'm sure you have the same or maybe even better surgeons over in Europe. There's no need to come to the US for that. But I think he just really wanted to come to the US at the time. And so we ended up saving him a trip to the US. And he said, oh yeah, I will make sure I eat better and get out in the sunlight and
Mm.
exercise a little bit. And so sometimes, I assume just because he's a chiropractor, he's healthy, and he was relatively healthy, but
Mm.
for some reason he was not getting out much. Maybe he was just too busy working, and didn't have time to eat a proper diet and proper exercise. But something like that, kind of causes me to think every once in a while, oh, not everything is just a run-of-the-mill traumatic type of compression fracture, or in an older person, say a 60 or 70-year-old lady, and I saw that, it's automatically osteoporosis. That's what
Mm.
we would say without even thinking, really.
Mhm.
But there's always, these weird ones that kind of come our way every once in a while.
Yeah, the story of a patient comes to mind, and he had an injury over 5 years previous, and he'd been through the whole system, went through rehab, didn't work. I think it was a motor vehicle accident. And then one day eventually ended up in a neurosurgical consult
Oh
office.
no.
And within a minute, the surgeon said, "You have a fracture in your neck," because of a
Ooh,
clinical exam finding. It was like, really?
for
He
five
stood up.
years.
It was crazy. A bit like what you're mentioning. All of a sudden you do the x-ray and you see it, and then his management was different. I think he did have surgery to stabilize it or fix it. But it goes
Mm,
to show, we can never be complacent about films. If things are not following a traditional path, we need to make sure we're not missing anything. And sure, it may take 99 normal films, as it were, or regular films to get the one fracture. It's definitely something that we need to be either reminding our physicians or the physicians listening to be doing, to make sure, because you never want to be the one missed at a patient or a doc in this situation. So that was kind of a horrific story. But it happens, it does happen.
it does. Not that often, but
Mm.
probably more often than we're willing to admit, or or at least
Mm.
more often than the average Joe off the street would know about.
And I
Um,
think something else I'm going to mention, and it's really based on the case about vitamin D deficiency. Let's face it, in the Northern Hemisphere here, especially in Canada, Europe, Spain, maybe you think of Spain as being sunny and beautiful. Well, yeah, but not all year, right? It's
mm,
still Europe. And we need our vitamin D, because we ain't going to get it in the sun because of our latitude in the earth, but we need to get it in supplementation. And that's something that I've woken up to in the last 3 years and made sure my kids get enough and I take enough. But yeah, like osteoporosis, we all kind of know what that is, thinning of the bones, and there's not really a metabolic problem like low calcium or high calcium. It's just a finding on a bone density scan. But no, vitamin D is absolutely essential to not just for bones, but our hearts and our brains and our immune system. And it's like a
I agree.
hormone. It's even more than a vitamin. It's like a hormone. It's essential to our well-being. And if people are not taking, people listening to this are not taking vitamin D, I personally recommend 5,000 units a day. If you're unsure, just get a blood level. I personally take more. I take 10,000, but my kids take 5. And I heard just 2 months ago that the Canadian or Health Canada it raised the level from 1,000 to 2,500 units as a recommended amount. So that's, great. 2,500 great is a good start in my opinion. 5,000 is probably more therapeutic, and 10,000 is just to make sure. But I've only come across one case so far that they had a blood test high in vitamin D, and then it's pretty straightforward. You just lower it till it's you get the right level. But
Oh, that's interesting. Good for Canada. I imagine the US FDA is a little behind. I think we're probably still, our RDA is probably at 1,000 or less, I imagine.
Okay, well, let's anything you want to share before I maybe wrap up with a question?
Oh, I wanted to mention that so what we do on a daily basis, helping chiropractors with their imaging, and this is just to, you're asking about, what I teach, anything, and I said anything to do with radiology, and I have a short course. It's probably only an hour, but probably could be a little bit longer, but it's everything to do with how to read the x-rays, just so you can get better yourself at it. And one of the things is, it's a fancy word. We call it inattentional blindness. And all it really means is that you're not paying attention when you're, when you're looking at these x-rays. And it's, unfortunately, I think it's very common. And I think it's a very common source of mistakes or missing things on an x-ray, even, very clinically relevant findings. And so I tell my chiropractors, it's it's a mindset you have to get into. Be dedicated for just, even if it's just for a couple minutes, looking at a set of x-rays or something, but that's the only thing you're going to do, for those 2 minutes, and don't let anyone distract you, because you could be missing something, and probably not very often, but the ones where we miss and that are clinically relevant, that could be a detrimental effect on your patients. And so a lot of it is just probably a source of or probably based off of our poor healthcare system, I want to say, at least in the US. I think it's better in Canada, where you are, Wayne, but everyone seems to be in a hurry down here, and everyone has jobs, everyone has things to do. Well, it's the same in healthcare. We want to get a lot done in in a short amount of time, and probably too short of a time, but we make sure we try to have, I tell all our contractors, if you don't feel like you have enough time, then we will not send you as many cases, because we want you to do a good job and have adequate time to read these things. And so I think a lot of our these uncommon misses could be solved from just paying a little bit more attention, and maybe giving just a little bit more time.
And any final comments to the audience?
Final comments, since you're chronic pain, I know it's a terrible thing to have, but it's something you don't want to give up on. And there are solutions out there. Many colleagues of mine that deal with chronic pain on a daily basis, probably similar to you, Wayne. And it's a big problem, but know that there are lots of people out there with it. You can I find comfort knowing other people have the same problems as I do. And even just, having a small community. So find your community and know that there are solutions out there, but they could be hard to find, they could be hard to find, but I'd encourage you, if you are a chronic pain sufferer, that to keep looking. There are lots of different options out there these days.
Exactly. Well, thank you again, Cliff, for coming on and sharing your insights, very unique insights into the world of pain. And it's great to meet you, and I look forward to meeting you in person one day.
Thank you very much, Wayne. Thanks for having me.